A very big hello to all my dear students. So today we are going to discuss about vitreous. Please give the heading vitreous. So in your MBBS you don't even study this chapter separately, but here we have to learn few important things regarding your entrance exams, right? Okay, so vitreous can be, I'm making it very simple, just focus and please keep making the cues. So vitreous can be primary, secondary or tertiary. So there are three terms here. One we are saying is primary vitreous, then we said secondary vitreous and tertiary. One by one, what is primary vitreous? The vitreous during embryonic development, that is mainly composed of hyaloid tissue, right? So it is hyaloid tissue. What is hyaloid tissue? Hyaloid tissue means hyaloid blood vessels with mesodermal tissue. This is what is primary vitreous. We will make the diagram to understand better. Okay. So this is the lens and this is the optic disc, right? So what we are saying, during the embryonic development, what happens? These are the hyaloid blood vessels just supplying the anterior. And along with that, the mesodermal tissue. So this whole thing is what is your primary vitreous. Now this is later on regressing and is replaced by secondary vitreous. So what is secondary vitreous? Is adult vitreous. What is it composed of? Question number 1. This is primarily hyaluronic acid and type 2 collagen. And type 2 collagen. Hyaluronic acid and type 2 collagen. Right? Okay. And what is tertiary vitreous? Another exam question. Tertiary vitreous is zonules of Zinn. The suspensory ligaments, they are nothing but tertiary vitreous. That is called tertiary vitreous. Third question. Secondary and tertiary, they develop from neuroectoderm. Make another cue here. Whereas primary develops from mesoderm. Mesodermal tissue, na? So mesoderm. Make another cue here. These are all cues. Right? Now we come back to the story that, okay, when this is regressing, right? What happens? We'll look at the slide here. Okay, so now we are going to look at the anatomy. What are the landmarks that you have to know? If you want to draw, you can draw it. Otherwise, just understand, we have drawn it earlier also. That this is your condensed part is called anterior hyaloid membrane. Right? Just behind the lens, all this. If this is the periphery, is the ora serrata, this vitreous is spanning around 3 to 4 millimeters. This is what is vitreous base at the spanning the ora serrata. So all this is secondary vitreous. And the primary vitreous, the blood vessels, they regress and this, that what remains after regression is Clockett's canal. Just remember that. Okay. So hyaloid tissue is regressing and what remains is the Clockett's canal. And of course the posterior is the condensed part is the posterior hyaloid membrane. This is the optic disc. Right. So this whole thing will become primary vitreous, which is regressed. And we all remember that patella fossa space of Berger, we have to discuss that in our diseases of lens. Right? So once you are clear with the anatomy of the vitreous, the next thing that you have to know that during regression, sometimes a part of the primary vitreous can be left. So the remnant of the primary vitreous can be of many types. So now learn with me the way I am talking. If during regression, a very small bit is left behind, okay? If a very small bit is left behind, this is seen as floaters to the patient. Floaters is the objects of something floating in front of the eye. And this is what is called musky volitens. We'll remember this, simple, musky volitens. Floaters are nothing but opacities in the vitreous cavity. Okay, if a larger chunk is left behind, then behind the lens, I'm making it very simply, in a very simplified manner, I'm making you to learn along with me. Then behind the lens, this is called anterior PHPV, persistent hyperplastic primary vitreous, and this is called near the optic disc posterior PHPV. Okay, we'll talk about few points in this also. First, keep listening. And suppose neither that big chunk, neither as small as musky volitens, anything in between. Like, so this is a way of learning that I'm telling you. So think like this, if anything in between is behind the lens, this is what is called Mittendorf dots. We'll look at the slides also. And when it is near the optic disc, this is called Burgmeister papilla. So, all of you, these are cues. Where do you get Mittendorf dot? Where do you get Burgmeister papilla? It is all, where is the location you should know, and that this is a remnant of hyaloid tissue. This much you should know. Okay. So, this is your remnant of hyaloid tissues. We are learning the remnants of hyaloid tissue. So, musky volitens, it could be Mittendorf dot, it could be Burgmeister papilla, or it could be anterior PHPV and posterior. Now, talking about anterior and posterior PHPV stands for persistent hyperplastic primary vitreous, right? So, the primary vitreous has been persistent. So, write down persistent hyperplastic primary vitreous. Persistent hyperplastic primary vitreous is PHPV, right? Now, what we are going to learn further, we just said it can be anterior or posterior, right? So, anterior, which is behind the lens, think yourself, will cause an opaque media, and therefore what will happen? It can lead to amblyopia. The main problem with the patient is this child will be amblyopic. Generally, it is unilateral and it may be associated with microphthalmos. So, posterior PHPV has got a poor prognosis, whereas anterior PHPV has better visual prognosis. And another, this is in relation to exam question, please note down, there is no calcification in PHPV. These are the few points which will solve our purpose. This was about persistent, and I think you have learned this. What is the cause of leukocoria? We have learned in the cause of leukocoria, persistent hyperplastic primary vitreous, right? Okay. Next thing they can ask you is about the attachments of the vitreous. When you talk about the attachments of vitreous, we will learn that vitreous attachments can be, let's draw it. So, one was your did we not learn about Wiegand's ligament? So, when anterior, and this is what vitreous base, which is spanning the ora serrata, will be this one. If this is the ora serrata, right? So, wait a minute. We should be making it like this. So, this is the vitreous base, which is spanning the ora serrata. Okay? Number one, I'll start with this one. So, this is your ora serrata. Then your next attachment that we can learn very nicely is, that is, okay, so base, and then what is this? Anterior hyaloid membrane. So if this is anterior hyaloid membrane, what was the attachment here? That was called Wiegand's ligament, right? So this is your Wiegand's ligament with the posterior capsule, right? The space is what is called Berger space. Now then, what are the other attachments? It is around the disc, at the disc. One is at the disc. So we are just learning the attachment here. This is at the disc. Then it can be at the fovea, and then it is at blood vessels, then the blood vessels. Right. So I'm just showing the attachment separately. We are not drawing the detailed anatomy here. So these are the different attachments. Vitreous base at the ora serrata, then at the central retina. Aise socho, go back to your retina structure. So at the disc, at the fovea, at the blood vessels, then anteriorly at the ora serrata, which is called vitreous base, and then of course posteriorly at the back of the lens, that is your Wiegand's ligament. Okay? So once we know these different attachments, the question they have asked you is, which is the strongest attachment to the retina? So what is the strongest attachment to the retina, or what is the strongest attachment of the vitreous? It is always vitreous base, okay, at ora serrata. So here we solve another important question. Okay? Okay, then we next talk about is, next heading is floaters. So what are floaters? Write down, these are opacities in the vitreous cavity. Opacities in vitreous cavity are called floaters. Now let us think together what can be the different opacities. So we make another quick diagram here. So if I talk about different types of opacities, one you have learnt is retrolental flare. So these are inflammatory cells, number one. This is retrolental flare or inflammatory cells. What is the next one? Second would be, so some pigments, right? Where did we learn about pigments? Especially when there is a retinal break, there can be dispersion of pigments, which is called tobacco dust, isn't it? Then third, it could be hemorrhage. A partial vitreous hemorrhage, the hemorrhagic clots are floating. So another one could be hemorrhage, right? What else? Next, it could be, very, very important question. This is also floater, synchisis scintillans. Now what is synchisis scintillans, all of you? These are cholesterol bodies, right? And they are generally seen in end-stage disease. And very important, when you ask the patient to look up and down, they are free falling. So the question has been asked on, what are they composed of? Come to the next floaters. So this was 1, 2, 3, 4th and 5th number, yeah? 4th and 5th is also an exam question, that is asteroid bodies. So when you say asteroid bodies, these are composed of, what are the points we'll remember about it? First, it is also called asteroid hylosis. Okay, number one, it is also called asteroid hylosis. It is composed of calcium and lipids. Composed of calcium and lipids. Now, it is generally more common in males. Does not affect the vision. Visual acuity is normal. Okay. Then it is not free falling. It is just seen to be fixed in the vitreous gel. It is not free falling. Then next, it is associated with diabetes, with hypertension, high cholesterol. It may also be associated with hypermetropia, but not, this is exam question, not with, see I am saying not with myopia. So it is not associated with myopia. So one question was on composition. Second question they had asked you which is the wrong statement, and they had asked you about association with diabetes mellitus with that. So it is not associated with myopia. We'll remember that. Okay? So that was about asteroid hylosis or asteroid. And of course, when you are listing the floaters, you should not forget to mention musci volitans, right? So what are musci volitans? These are remnants of hyaloid tissue. These are remnants of hyaloid tissue. Okay, so this is all about the floaters. Let's have a look. So the next slide that we have is this one. Absolutely very difficult to say generally, is it asteroid hylosis or synchisis scintillans, unless you move the eye and see whether it is free falling or not. But as of now, if they ask you, ye batao, then I am going to say it is asteroid bodies. I feel it is fixed. Why should I say anything else? Right? But you have to actually see it clinically properly. Now, of course, this is your hemorrhage in the vitreous, the blood in the vitreous here. Can you see that? Appreciate that? It's floating in the vitreous. That's why it's all hazy. Again, see, everybody knows this is a B scan now. And this side will be the lens. This is the vitreous. Can you see the opacity? This is what is vitreous hemorrhage. the hyperechoic area, right? Again, this is a vitreous. This time it is this big hemorrhagic clot, and these are the hemorrhages in the vitreous. This is a generally case of PHPV, persistent hyperplastic primary vitreous. Okay, so what was back of the lens? This is what is Mittendorf dot. And when this is what is Buckminster papilla. We just learnt it. So Buckminster papilla is what? It is remnant of hyaloid tissue at the disc, and just behind the lens, this is called Mittendorf dots. Both are remnant of hyaloid tissue, right? Mesodermal tissue. Again, what are you looking out here? Is Buckminster papilla. This is Buckminster papilla. Okay? So that was all about vitreous. If we know this much, we are going to answer all the questions. So that's it. Thank you so much. Stay blessed. Keep smiling.